So welcome everyone to this Fujita-Bantané Alumni Association webinar, which is a special webinar today as we are organizing this in conjunction with the Women in Neurosurgery chapter. So I want to thank Dr. Sharon Theophilus to share this webinar with us. Before starting introducing our speakers, I want to welcome Professor Yoko Kato, of course, our mentor, and ask her to give a few words as introduction to this webinar. Thank you, Professor.
So thank you very much for invitation. So I'm very happy to receive the conjunction, the alumni with WIN. So Dr. Sharon and Lene, thank you very much for your efforts. I'm very happy to see your all nice face. So we're very much looking forward to the lectures. And maybe at the last, maybe we can introduce the newcomer, new alumni member. Two nurses from Hanoi, one from Armenia, hopefully. Thank you.
Thank you, Professor. Yes, as always, we will welcome the new fellows at Bantané Hospital today. Let me also thank Raja and Bong Liu for their support, constant support, tireless, I would say. Today, we have two speakers. One is Professor Abida Shah from India, and the other one is Dr. Yu Xinli from Malaysia. They will talk about very interesting topics. I want to also welcome and thank Dr. Dilshad Mabadaliev and also Dr. Lin for being here as commentators. And of course, our discussants, Yassine Felissi, Sukirti Chawan, Shawanas Biswas. So we can probably start. I would like to introduce Dr. Sharon Theophilus. Please, you want to say something just to start this webinar and maybe to introduce our first speaker.
Thank you very much, Alberto, and thank you again to the Fujita alumni for inviting WIN to join in this webinar. It's a great pleasure and an honor, and we hope we can do more joint webinars like this. So it showcases a bit more of the women neurosurgeons to everyone. So of course, without wasting much time, I'd like to introduce our very own secretary of our WIN. She's also, I think, doesn't need much introduction. Everyone knows her very well. I'm also very proud to have her in our team, Professor Abida Shah. Her accolades are actually very, very long if I want to go through them. I think everyone knows she's done a lot of publications, and I think she's actually encouraging a lot of us to do more publications, especially the women neurosurgeons, to put your mark out there like how she has done. She's also at the moment has editorial positions as associate editors in the Journal of Craniovertebral Junction and Spine, and also associate editor in the International Journal of Neurology and Neurosurgery, and in the editorial board of International Journal of Neuroscience. At the moment, she's also holding a post in the leadership post in India. She's the executive committee member of the Neurological Society of India. So without wasting much time, today she's going to talk to us on nuances of fixing the craniovertebral junction. So Abida, the floor is yours.
Thank you, Sharon, for this introduction. And thank you, Professor Kato, for this invitation to present, and Dr. Alberto. And it is a good plan to have a combined webinar of Fujita alumni and the WIN, so that, you know, our group becomes larger and the message goes across towards more younger neurosurgeons over the world. So I'm going to be talking about nuances for fixing the craniovertebral junction today. This is a topic that is close to my heart. The technique of craniovertebral junction fixation is described by Professor Goel, and I'm very happy to have learned it from him and practicing it on my own now, fixing the craniovertebral junction. But as you all know, that the craniovertebral junction is a very unique masterpiece, and it has very unique difficulties when you're treating it or accessing it surgically. So it is very important to understand the anatomy of this region so that you know all the nuances that you can use to fix the craniovertebral junction. So this craniovertebral junction is the center of stability by means of the occipito-atlantal joint, and is the center of mobility by means of the atlanto-axial joint. Now, if you see these structures in the vicinity of this region, so the most important vessel here is the vertebral artery, and there are a lot of venous plexuses in this area. So when you are operating in this region for fixing the craniovertebral junction, these are the two main structures that are actually can cause a hurdle in your surgery. So let's start a little with the bony anatomy. So this is the foramen magnum. As you can see, it is wider anteroposteriorly than transversely. It is formed by the occipital bone. The occipital bone forms part of the clivus, the rim of the foramen magnum, and this is the squamous part of the occipital bone. These are the occipital condyles. So you see how sturdy these condyles are, and they have a convex configuration, and they articulate nicely with the superior facet of the atlas. So this is where the condyle articulates. And as you can see, there are these curves here, these upward facing curves, which actually gives a lot of ligaments which give a stability to this region. And hence this occipito-atlantal joint is quite a stable joint, and it is very difficult to break it open or to have instability at this joint. Whereas the atlanto-axial joint, this one, is a unstable joint. In the sense, it has a lot of mobility. It is responsible for your rotation movements in the neck. And because of that, there is a lot of leeway. You see, this is the superior facet of C2, and this is the inferior facet of C1. And if you see, they don't have a very fixed configuration. So there is a lot of mobility that is possible in this region. And because of this mobility, the joint is also prone to instability. If you see this C2 bone, this is an atypical cervical vertebra. This is the odontoid process. This is the superior facet. This is the inferior facet. So unlike other subaxial cervical spine, the superior and inferior facet, where they are one above the other, here there is a region here, the pars interarticularis, which connects the superior and inferior facets. And there is a difference in the pedicle and body also of this bone. Similarly, C1 is an atypical vertebra. It does not have a body. It has anterior and posterior arches. So coming back to this image, if you see the course of the vertebral artery, it comes out here from C2, goes on the superior aspect of the posterior arch of C1, and then traverses here medial to the atlanto-occipital joint to enter the cranial cavity. The region of the foramen magnum. So where does the brainstem become the spinal cord? And is in the region where the C1 nerve root emerges. So this is where you call the actual transition of the brainstem from the spinal cord. Also, there are so again, this you can see the traverse of the vertebral artery here coming on the posterior arch of C1 and then going here medially. This is the occipito-atlantal joint, and here you can see the artery entering medially. There is another important structure here whose anatomy is important when you're working on the C1, C2 joint, and this is the C2 ganglion. You can see it in this image also. So the C2 ganglion is actually outside the intervertebral foramen, and it lies on the C1, C2. I will show you on the other images where it lies exactly. So this is another anatomical structure that you must understand. The vertebral arteries are important. As you know, both the vertebrals join on to form the basilar, and injury to this can cause a neurological deficit. So this has to be avoided at any cost. Now let's come back to the technique of C1, C2 fixation. So this was described first by Professor Goel in 1994. After that, we have got thousands of cases that we have done by this technique. And this was his first case where he put a screw in C1 and a screw in C2 and then connected them with a plate construct. So this was one of the youngest childs that we have done with using this technique. So I think this one was 4 months old. And here you can see the fixation of the C1 and the C2 region. So everything in the craniovertebral region or in majority of the spine revolves around the facets. The facets are the strongest, and you have to utilize the cortical bone nature of this facet for performing the fixation. Also, they are responsible for a lot of instability. So if you consider basilar invagination, the basilar invagination is not a fixed anomaly. It is actually a mechanical instability, and that is related to instability of the facets. So earlier, we divided basilar invagination into two groups, Group A and Group B. Group A was where the odontoid prolapsed into the spinal cord, and Group B was when the whole system moved up above the chamber lines, but the odontoid did not cross the 𝒂𝒂𝒏𝒈 line. Here you can see that the odontoid has crossed this 𝒂𝒂𝒏𝒈 line. In Group B, it does not cross this 𝒂𝒂𝒏𝒈 line, but there is basilar invagination with respect to the Chamberlain's line. So at that time, the treatment of Group A was thought to be craniovertebral realignment and fixation, whereas for Group B, we performed a foramen magnum decompression. So if you see this, how is it related to the joints? So if you see the joints in basilar invagination, you see that they are abnormally inclined. It is the mechanical instability that increases its inclination of the joint. The joint is not fixed. It is actually mobile or hypermobile. And you see these various images of joints, and you see how the inclination is different. And that is what causes the listhesis or the so-called basilar invagination. So just like a lumbar listhesis, this transatlantic odonto-occipital listhesis is basilar invagination. So just to show you a few images before I go into the technique. So here you see the odontoid, here you see the joints, and this is after fixation when the whole craniovertebral region has been realigned. This again another patient with a basilar invagination, a syringomyelia. You see how abnormal the joints are. There's actually a mess of a joints. You have to work in these joints. You have to know how to reach these joints and then maneuver them so that you can realign them and result in a cure for this basilar invagination. Along with this basilar invagination and the bony abnormalities and the Chiari and syringomyelia that you observe, there were a lot of other musculoskeletal anomalies that we observed. That was this torticollis, this reduction in the neck length, which reversed after fixation. So after fixation in the immediate postoperative period, the torticollis resolved. The neck size, the neck length actually increased, and you can see the smile on this patient's face. So you see, these are the abnormalities associated with basilar invagination. There is a Chiari, a syringomyelia. See the joints that are abnormal, and you can see that the fixation has resulted in reduction in Chiari and syringomyelia. Now, moving forward, where we said earlier that for Group B, we were propagating a foramen magnum decompression. Now, you see in this image, there is no basilar invagination. There is only a Chiari and a syringomyelia. So, even for this, now we have realized that even in patients with Chiari, this Chiari and syrinx are only manifestations of the chronic atlantoaxial instability, and fixation of this joint will lead to reversal of these changes and an improvement in the clinical symptoms. So this is Group B basilar invagination, where you see that the odontoid has not crossed the clival line, but it is still basilar invagination where it is above the Chamberlain's line. There is a Chiari and a syringomyelia, and this is after fixation. Only you can see that the Chiari has reversed and the syrinx has decreased in size and the patient has improved clinically. So we have a lot of images which show now, and more than the images, it is the clinical improvement in the patients that is a proof of the pudding that the technique works and the philosophy is correct. We also used a lot of monitoring during the procedure, and you will be surprised to know that after fixing the joint, after putting the screws on both the sides, there was actually an increase in the MEP that we documented. So you see, this was the original MEP, and this is the MEP, the improvement in the muscle power immediately after fixation, which gives credence to the hypothesis that instability is the cause of Chiari formation. Now let's come back to the technique. So as I was telling you, this is the C2 ganglion, and it lies outside the intervertebral foramen. And if you see, I've lifted the C2 ganglion here, and you see the atlantoaxial joint. So this C2 ganglion is actually a window to the atlantoaxial joint. And sometimes in cases of high severe basilar invagination, you need to cut this ganglion so that you can access the C1, C2 joint. It is a very important landmark to this C1, C2 joint. Again, here you see the vertebral artery and the venous plexus is in this region. So what are the important parameters that you have to remember when you're fixing the craniovertebral junction? So for this, we studied this in 1988, and you see that the pars was divided into 9 quadrants. This upper and superior medial quadrant is the safest for C2 screw insertion, because even when the vertebral sometimes is high riding in the superior facet of C2, if you use this landmark, then you will avoid injury even to a high riding vertebral artery. So that is the importance of this point of insertion of C2 screws, because that is the most difficult part of this operation, so that where you can cause injury to a high riding vertebral artery. So that is what you have to remember, that you put the screw in this region, in this quadrant, and you will avoid injury to the vertebral artery by using this. So now let me show you a video with the technique. So this was a 12-year-old male child who presented with neck pain, back pain, and scoliosis. On examination, there was spasticity. Now you see there is subtle atlantoaxial dislocation. There was a Chiari and a syringomyelia, as you can see here. This is the joints. You do not see any manifest instability in the joints. Now you see this is the position. It is a head-high position. It is lying on the headrest. It is floating. This region is also exposed because we take an iliac crest. This is the incision. The incision rests on the C2 spinous process. It is 4 centimeter above and 4 centimeter below the C2 spinous process. So the first thing is you go and expose the C2 spinous process, and then with subperiosteal muscle dissection, you expose the region. So here you see this is the C2 spinous process. This is the C2 lamina. Now this region is loaded with venous plexuses. So when you are operating in this region, you have to know the art of tackling this venous plexuses, because they will keep on coming in your way, but you cannot keep on coagulating in the region, because that will not work. You have to learn the art of using Surgicel and gel foam, and work among bleeding to actually access the region and do a fixation. So this is the C2 lamina. Now tracing the pedicle. Tracing this region will lead you to the C1, C2 joint. This region is laden with the C2 ganglion and the venous plexus. So in the majority of cases now, we do not cut the C2 ganglion. But as I said earlier, that if the joint is too high, or if there's severe basilar invasion, you may need to cut this ganglion. So this is the drilling of the C2 pars pedicle, so that we can accommodate the plate. We always use a plate and screw construct, not a rod and screw construct, because this is more stable as it lies on the bone itself. So now this is the C1, C2 joint. You can see there is an osteotome that we have inserted, and this is the primary hole that is being made in the C1 facet. So that has to be directed medially and superiorly towards the C1. After doing that, we insert bone graft from the iliac crest into the joint. Now this is the key to the surgery. Your metal implant is going to hold the region only for a short period. It is this bone graft that is inserted into the C1, C2 joint that will actually cause the fusion and will hold the metal implant after 3 months. So now we have inserted the bone graft, and the plate and screw is being inserted into the C1 joint. After that, you work the plate around to come to the originally drilled area. Then you make a hole in the C2 pedicle, and then under vision and directing it superiorly and medially, you enter the C2 screw. Now you will see it. So it is completely under vision. The medial border of the pedicle is under my vision, and I'm inserting the drill bit inside. So I know exactly where I am, where the vertebral artery is, where the medial border of the dura is. So there is hardly any chance of vertebral artery injury. Even with taking so much precaution, sometimes, very rarely, in a high riding vertebral artery, you can have a problem. And that is a different topic to discuss. But majority of the times there is no issue, and you can easily insert the C2 screw. So now this is the C2 screw insertion. Now we tighten the screws later. This is on the opposite side. Now we'll not go faster now. So this is the C2 screw insertion on the opposite side. And this is the final tightening of both the C1 and the C2 screws. And this is the last important step of the surgery. You have to disconnect all the muscles that connect to the C2 spinous process, so that the whole region gets a chance to heal without any mobility that is caused. So you decorticate this whole host bone area of the C2 spinous process, of the C1 arch, and of the C2 lamina. and then you put the harvested bone graft from the iliac crest over this region, and that will ultimately cause the bone fusion. And this is the post-operative image, and needless to say that the patient did very well following the surgery. Now what happens? So this is the normal anatomy where you do a normal C1, C2 fixation. Now what happens when the course of the vertebral artery may be abnormal? So to identify this vertebral artery course, in many of our patients, we performed this 3D models. In some complex craniovertebral cases, we perform these 3D printed models where you can see the course of the vertebral artery. So here you can see it is lying over the C1 joint. Here it is again going over the C1 lateral mass. Here again, it is lying medial to this joint. So in this time, you have to be more careful when you're performing the C1, C2 fixation. So now you see this patient here, the vertebral artery is actually lying over the C1 lateral mass. So your C1, C2 screw, the C1 screw insertion has to be modified accordingly so that you can appropriately not cause any problem. So in this patient, what we actually did was, on one side, we did a C1, C2 fixation, and on the other side where the vertebral artery was, we just put a spacer in this joint, and which is known as joint jamming, and I will show you that also later. What to do in cases of a high riding vertebral artery? So now you see this is the superior facet of C2. So sometimes the vertebral artery comes all the way here into the most superior and middle aspect of C2. And in this situation, the C2 screw insertion can be a little challenging. So what you have to do in these cases is you have to mobilize the vertebral artery so that you have this space available for inserting to the C2 screw. And this is the technique that we also recently described of mobilizing the vertebral artery and then creating this area where we can enter the C2 screw. So I will show you this video also. So this was published in Operative Neurosurgery. So this is the patient with an os odontoideum. You can see the mobility. You can see that the facets are aligned. Now you see the high riding vertebral artery in this C2 facet. So usually on this image, you can identify this, the high riding nature of the vertebral artery. This is again the position. Now you can see this video. So we have already shown you this part of the surgery in the other video, so I'll go a little fast. So on this side, the vertebral artery was normal, and we proceeded with the regular C1, C2 facet fixation in this on the left side. So the same technique. So C1, C2, C1 insertion. Here you can see the vertebral artery is right here, but it is not high riding. And you have this space for C2 screw insertion. So on this side, we use the normal technique of inserting the C2 screw. Now let's go to the opposite side. So this is on the right side now, which has a high riding. Here you can see the vertebral artery. So you see there is a very thin pedicle here, and the vertebral artery is actually coming on the way of our C2 screw insertion. This is the C1, C2 joint. So now you see the vertebral artery, and this is the only area that is available. Or mind you, this is high riding. So this vertebral artery will actually go in this part of the superior facet. So if you insert a screw just like this, there is a high chance of damaging this vertebral artery. So first, as usual, you insert the C1 screw. You put bone graft into the C1, C2 joint. And now you see what we do for inserting the C2 screw. So this is the vertebral artery now here. Now you see that we are removing the bone of the vertebral artery foramen and making space to mobilize the vertebral artery so that we can bring it away from the field of screw insertion. So after drilling in this area and reaching the vertebral artery, you actually remove some bone here and try to mobilize the vertebral artery. So now you see that with this structure, we have pushed the vertebral artery down. And this bone is now being exposed here, which is now safe because the vertebral artery is now mobilized downwards. So now we drill the hole in this region, protecting the vertebral artery down here. You can see now the vertebral artery I'm pushing down, and then the C2 screw is being drilled, and the screw will be inserted in this region so that there is no chance of damage to the vertebral artery. And then you perform the fixation similarly and you put the bone graft. So as you see in this image, apart from the C1, C2 fixation, apart from the mobilization, there is a lot of venous bleeding. There is a lot of bleeding in this area. So you have to be a little bit used to this bleeding, and you have to learn to work within it, especially in some cases of basilar and Chiari. There will be a high degree of venous bleeding that may cause, more problem to you when you're operating. So this was the paper on mobilization of the vertebral artery. And you see, this is the post-op image. See the high riding vertebral artery, and see the screw here. The vertebral artery is pushed down and the C2 screw has been inserted. So this is again another patient with a high riding vertebral artery where the C2 screw is inserted. So these are the regular techniques of fixing the C1, C2 region. Sometimes you don't have a seat. There may be an absent C2 pedicle. While you're doing the screw insertion, the C2 pedicle might break. Then what do you do in such a situation? You should remember that you have an inferior facet, which is also strong and which is also a thick cortical bone. So if there is a problem in inserting your C2 screws, we insert the screw into the C2 inferior facet. Sometimes just taking the C2 facet, sometimes going all the way to C2-3 and taking the whole region in this construct, and which can give a solid fixation. So you see this patient had a high vertebral artery, and there was a lot of bone loss in this patient. So in this, we said put a C1 screw and then use the C2 inferior facet for the second C2 screw. This patient had absent C2 pedicles. So there is no chance of having a C2 pedicle. So one screw in the C1 here, and the other screws bilaterally were inserted into the C2-3, going downwards and directing it inferiorly. Then the next technique is just the use of these metal spacers. So this was described as a standalone technique, and it was called as joint jamming technique. The indications of use of spacers in this thing has reduced markedly, but still it is a salvage technique, and it can be used like in this situation where the vertebral artery is in the way. On this side, you can see that we've just inserted a spacer, and on the other side, we have done a C1, C2 fixation by the regular way. So you can do a lot of combination strategies for fixing the C1, C2 region. Now, this is again another technique. Sometimes the basilar invagination is very high, especially in group B or severe group A basilar invagination, where you're just not able to expose the C1, C2 joint. In that situation, we make a small craniotomy just above the C1, the occipital C1, the whole condyle and atlas assimilated mass. And then from above down, we insert the C1 screw. So you can see this image. You see how high the basilar invagination and the joints are. So you see that small craniotomy, and then you just insert in this direction, the C1 screw. So coming from, you can see, visualize the region from top, and then you can insert the C1 screw. The C2 screw is the regular one. Again, you see this high basilar invagination, and you see this small little bone that we've removed so that we can insert the C1 joint into the assimilated atlas. Again, a severe basilar invagination. You see how rostrally the joint is located. It is quite difficult to perform from the regular way of C1, C2 fixation. So you see in this, we have used C1 transcranial screw. On the other side, we have done transarticular screw. And here we have used C2 inferior screw. So you can see, because of the familiarity of the anatomy of the region, you can mix and match the strategies and perform a C1, C2 fixation. This is a very old technique described by Professor Goel, where he used to insert the C2 screw in the spinous process. We don't use this anymore, but this was also first described by him long back for, the going into the spinous process and the spinolaminar junction, which here you can see the spinolaminar junction. Then these are transoral plates. This one is, of course, going into the spinolaminar junction. Even transoral plating of the craniovertebral junction was described first by Professor Goel. So nowadays, we have abandoned this technique of occipitocervical fixation. We use all the strategies and tricks and tips to fix it in the C1, C2 region, and we don't usually need any reason to fix the occipital end to the plate to the occiput. We just use a plain C1, C2 fixation. And for those who are interested, these are a few of the seminal papers on the subject of craniovertebral junction, and I would welcome you to read this. Thank you very much for your time and invitation.
Thank you, Abida, for a very informative and interesting talk. I think, Sharon, we can open the discussion. First, I would like to ask our commentators, Dr. Lynn Lucina and Dr. Dilshad Mammadaliev, to give their comments.
Yeah, hello. That was really a very good discussion. Abida, I've always admired the way that Professor Atul Goel and then now the mentee, Dr. Shah, who has been always talking about this. And I've every time I attend, I learn and relearn because this is not really familiar to me here in the Philippines, you know. And what I'm saying is that sometimes we just take a look at the torticollis or neck pain, and we have not really been taking note of this here in the Philippines. And maybe it's time for us to see and do what are the basic workups that we should really look out for. Are these cases have some predisposition for genetic or maybe racial? Not just because we know a lot of this may be trauma or congenital. So, what are the other situations that we can find these cases of basilar invagination and also dislocation? And number two, what are the very basic things that we should look out for and work up here in the Philippines so that we can take note and address this, not just maybe doing therapy or anything. It may be a more serious case. So, yeah.
Thank you, Lynn, for that question. So basically, we have a lot of these anomalies in our country. Especially even in our country, there are certain regions that are predisposed to having this anomaly. A lot of basilar invagination also seen in Brazil and also in China. The reasons are not very well known. In India, at least, we attribute this to probably some poor delivery practices. A lot of our delivery practices in villages are still, they are home deliveries. There are use of forceps and undue force, which may predispose to some subtle instability and which may give rise to the problems and complex things that we see later on presenting in adulthood or, in young children. So that is one region. The second thing is if you want to identify a craniovertebral region problem, you have to see some markers. For example, if there's a short neck and torticollis, if you see a low hairline, if your hairline is going pretty low. For us, actually, when our one patient walks into our OPD, majority of the times by looking at the patient, I will be able to tell you that there's a craniovertebral problem. That is how familiar we are with it. The walk will be spastic. From the walk, you can make out that there is some problem. The torticollis is also very, there are different kinds of torticollis. You have spasmodic torticollis, but this torticollis is different. It is a congenital one, especially accompanied with a short neck. Once you see it, you will be able to recognize it. Sometimes the ears are low set. Sometimes there are associated anomalies. The stature of the person will be short. They're generally shorter than, their brother or someone else in the family. So these are some markers that you can look out. Once you see this, what you should do is first two things you have to do: MRI of course, the craniovertebral and cervical spine, but also a dynamic cervical imaging, a dynamic flexion extension imaging of the craniovertebral junction, which will show you the joints, which will show you the instability. But of course, we have now gone beyond the radiological imaging, and even if we see a malformation, something like a Chiari or syrinx, we attribute it to the atlantoaxial instability. So these are the basic investigations that will help you getting into, identifying these craniovertebral junction anomalies.
Thank you so much.
Dilshad?
Thank you so much, Professor Shah. That was very exciting, excellent presentation. I also interested in this topic during the conference in China, in Tianjin. I have a direct talk with Professor Atul Goel, and we have discussed several cases in the round table. So it was very interesting to me to get to know this new technique for us, but actually it has been done for many years by Atul Goel and you. So regarding the surgical technique, I have one question. There is in operation room, patient position is prone, and I saw the skull was there is a distraction of the skull. I guess this is this will be and some kind of enhancement for the approaching the joints, or is it mandatory to do this traction? I mean the traction. Yeah.
So I understand. So a lot of people used to use pre-operative traction. We don't use it. Only time we use it is intraoperatively. So what this traction does is actually it stabilizes the head. You're putting the head on a tongue and it helps you keep the head floating so that your eyes are not resting on your headpiece, on your horseshoe. So there are two purposes. It helps a little bit with the distraction, but not significantly. What the distraction is I'm doing is intra-op with an osteotome. So this is just to stabilize the head and keep it in a very good position for operating. So we use it only in drop. As soon as the patient is done, we remove it. We do not use any maneuvering of the head or anything like that during the surgery. Everything is in the C1, C2 joint.
Okay, thank you so much.
Professor Pirzad from Afghanistan, please.
Assalamu alaikum. Konnichiwa. Thank you very much. Congratulations for your achievement and nice and teaching presentation. It was so helpful. I like to know your advice for centers and countries. They haven't facility for stabilization, especially C1, C2 fixation, cranial cervical fixation. What is your alternative method for these centers for stabilizing the C1, C2? Thank you very much.
I don't think there is any alternative. You must learn this C1, C2 fixation. It's not very difficult. See, you do not need a C-arm. All right. If you know the anatomy, you don't even need a C-arm. We don't use a C-arm at all. We don't use navigation. When you're learning, maybe yes, you can use, but even if you're constrained, you go to the cadaver lab and learn the anatomy. Once you're doing it, you're completely under vision. This is the best way to stabilize the region. You know, all the sublaminar wires, the occipitocervical fixation, they do not give a very strong stabilization. And you're anyways exposing the region. So I would recommend that, you know, your fellows maybe come to us and learn it, and I'm sure you will be able to perform the C1, C2 fixation.
Yes, thank you. But also the implant also is impossible. We don't have in the market, in the Afghanistan market, and it's also difficulties. And you know, we now there is sanction and not we don't find good quality instruments in the market, and we hope that we find the border open, and we will send training for you. Also, we buy instruments from the market, inshallah.
Yeah, thank you.
Thank you. Thank you very much.
Thank you. And Dr. Neyamot?
Okay. Hello, Abida.
Hi, Niyamat. How are you?
Hi, nice to meet you. I'm basically inspired to do C1, C2 fixation after my last meet with you in Dhaka conference. I'm from Bangladesh. So I told you I have no interest in spine, but after talking with you, I get some inspiring, and I'm doing C1, C2 fixation and Chiari malformation for last 3 years. And there is about more than 50 cases, and all this for you. Thank you very much. And I have one question. In my last case, my C1 screw is just went beyond a few millimeter in front of the C1 anterior arch. So my question is how much length of C1 screw can be could be go beyond C1 arch would be considerable. And my second question is, all of your cases in Chiari malformation, do you fix the C1, C2 joint?
Yes, we do fix all the cases for C1, C2 joint. We do not do any decompression, only C1, C2 fixation. So that is the second question. The first question is, you can go a little bit beyond 3-4 mm is okay to get. If your C1 screw crosses the anterior border of the bone, that is fine, 2 to 3 mm, but not too much. So generally for adults, we use a 26 millimeter long screw. So, that generally serves adequate. Is adequate.
26 for C1 arch?
C1, yes.
Okay. Oh, thank you very much.
Thank you. Raja?
Yeah, hi. Thank you, Dr. Abida, for this wonderful session. I went to Professor Goel's place right after my MCH, and I observed directly from them how they do it. And it was started in our department 10 years ago on my suggestion that we did it. So we have done a lot of C1, C2 after that. This question is a technical one, as what is the type of screw now you use? Because you said that you are not cutting the C2 ganglion. So is it a partially threaded or a fully threaded screw? Because sometimes this thread may go and irritate and cause some occipital neuralgia due to C2 ganglion irritation. So many others have recommended to use a partially threaded screw. So a smoother one is outside, and so that it may not irritate. The second question is that when both the screws are of the same size, they will be at a different level. So do you use a longer screw in C1 and shorter in C2, or both the same screw? Because if you want a reduction, then the C1 and C2 will be of two different sizes, because when you plate it, it will come back. So what is your suggestion?
First, tell me, you're using the rods or the plate?
We are using the rods, of course.
That is why you are having all these questions. The
Yes,
first thing is shift to plate. I'll tell you why. See, the plate, when you put, it is abutting the bone. So all your thread part of the screw is inside the bone. There is nothing outside to irritate the ganglion. The ganglion will lie nicely on the plate. There will be no irritation once if I've not cut it. So first thing is, because of the plate, we don't see this problem at all. And your second question is, again, because it is the plate, we drill the parts so that the plate settles on that area and then make the C2 screw. Generally, the length of the screw for C1 and C2 is the same. It is 26 mm, maybe 2 mm here or there, depending on how the joint is. But because they are plate and screws and not rod and screws, that this difficulty does not come. The reduction is by that osteotome, which is in the C1, C2 joint. So that is what I'm primarily using for reduction, not the tightening. The tightening is in the end. We tighten the C2 screw first to maintain the reduction.
Okay, thank you.
Thank you. Sukirti?
Hi, Dr. Abida. Thank you so
Sukirti.
much for an excellent lecture. And like everybody knows in our country, you're also one of the pioneers of this 3D recon. So my question is, when we are planning the surgery, is 3D reconstruction on the CT angio good enough, or would you still give leverage to the physical model? And how much is it advantageous to the beginners who do these cases? Just a general message for everybody in that manner.
So if it is not a very complex case, the 3D CT suffices. So we don't use the models for all the patients. It is only in this complex, severe basilar invagination where you are suspecting a vertebral artery anomaly. And that's where we do it. Or sometimes when the joint is very high, because that model's presence gives you a landmark of the bony anatomy. Sometimes you're actually, I'm twisted like this when I'm operating on the craniovertebral junction, because the microscope is like this and the joint is that high. So when you don't have any landmarks, keeping that model just gives you a sense of the nature of what is happening in the operation theater, because that model is lifelike. It is the same as the patient's anatomy. So only in these cases we use the model. Otherwise, the 3D CT is enough. You don't need the models for all the patients.
Thank you.
Thank you, Sukirti, and thank you, Abida. Abida, one more question. How extensively do you use intraoperative neuromonitoring, in particular during positioning the patient? I'm asking because sometimes when we position this kind of patients with cervical instability or myelopathy, we experience the decrease of these neuromonitoring potentials, and we had to reposition the patient. So I'm wondering if you use and how extensively you do use.
Alberto, we don't use intraoperative monitoring.
You don't use?
We don't use. The only time we used it was during those few cases where we are seeing what was happening during the fixation. So that's when we used it. But I'll tell you, what you do is when you're positioning is you have to position yourself. And when I've put in the traction, I'm holding the traction in my hand and someone is stabilizing the neck. So it is a very well done routine in our department. And that's when I will turn the patient. So there is no inadvertent movement because I'm already giving traction to the neck so that whatever mobility is there is under my control. And then someone is stabilizing the neck and turning. Maybe next time I'll show a video of how we give the position, and we don't generally have a problem when we're doing that.
So no problems with positioning of these patients. Okay. Thank you, Abida. I see there is one more question.
Hello, thank you very much for the presentation. It was really great presentation. So I have a question, Professor. Do you have experience of in basilar invagination, the occipital spondylolisthesis followed by the transoral or transnasal removal of the odontoid process?
So this was done long. I don't have any experience because I haven't done any transoral odontoid removal, but this was done long. The genesis of craniovertebral stabilization has started in my department by, some pioneers and also, of course, by Professor Goel. So he used to do a lot of transoral release, transoral removal of the odontoid for group A basilar invagination, and then sometimes combine it with the fixation. But now, since we are able to realign the whole thing from posteriorly, we don't use a transoral or an endoscopic odontoid removal. The indication, I'll tell you, in my whole practice, I have seen maybe 3 or 4 cases of transoral surgery. I haven't seen nor done.
Thank you very much.
Thank you. I think we had a very fruitful and extensive discussion after your lecture, Abida, as always happens. So thank you very much. And Sharon, I think we can move on to the next speaker, who is Dr. Yu-Xin Li. Let me introduce Dr. Yu-Xin Li. She's a fully trained neurosurgeon in Malaysia. She is well experienced in performing complex brain and spinal surgeries, and in particular, she has a specialty in epilepsy surgery, endoscopic surgery, and minimally invasive techniques for tumor resections and also trauma care. She was trained in Malaysia, but she also had fellowships abroad, also in Japan, under the supervision of Professor Katsumi Takizawa. She got several achievements for her skills and publications, and she will lead us from the craniovertebral junction to the brain, as she will talk about 10-year single-center analysis of seizure outcomes following anterior temporal lobectomy in patients with temporal lobe epilepsy. So Dr. Yu-Xin Li, the floor is yours.
Thank you, Professor Alberto, for the kind introduction. A very good evening to all. I would also like to thank Dr. Sharon, who is my mentor since 2014. Thank you very much for the invitation to give this talk. So currently I'm doing a fellowship in epilepsy functional neurosurgery, and my supervisor on site in Malaysia is Dr. 𝒂𝒊𝒏𝒈 Azli. I would also like to introduce my team members, Dr. Fazana and Dr. Muhammad Adam, who had been working hard to make this data possible. So a little bit of my hospital. This is Japan here, and the brown dot there is Malaysia. So quite a distance there. And my hospital here is in the state of Selangor. So my hospital was established in 2006. It is a regional hospital which provides treatment for cranial and spinal neurosurgical diseases. It is also a center for epilepsy surgery, neuromodulation, such as DBS, VNS, intrathecal baclofen pump. We also do complex vascular cases and also high-grade glioma using fluorescence surgery. We have 10 neurosurgeons, including Mr. Liu here, covering a total of 4.4 million people. 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 4.4 million people So the ratio is about 1 to 440,000 people. We provide extension of services to 3 other regional hospitals, namely Selayang, Shah Alam, and also Klang Hospital. So back to the topic. So as I think we all know, epilepsy is a serious worldwide health problem affecting approximately about 1% of the general population. So, but unfortunately, 20 to 40% of these patients continue to have seizures and are known as this pharmacoresistant group. In temporal lobe epilepsy, the most common cause would be hippocampal sclerosis. Mostly they cause these focal seizures and also refractory seizures among adults. It is usually associated with poor long-term intellectual, psychosocial, and also poor quality of life. So our hospital offers a surgical intervention for epilepsy surgery, which is ATL, anterior mesial temporal lobectomy. So it is the most common surgery for refractory epilepsy. Technically, it's easy. You must be equipped with adequate 3D knowledge. It's very cost-effective, doesn't cost much to learn, and also doesn't cost much to do the surgery. Very minimal complication and very good outcome if done correctly. So these are some of the studies done internationally comparing the seizure outcomes at 1 year post-surgery. Most of the studies that I quoted are more than 15 years ago here. So the criteria for surgery here in my hospital includes uncontrolled seizures on medications for 2 years or more, and we've already optimally trialed them on 2 or more medications, but failed to achieve any seizure control. Doing MRI, we can identify a lesion or region of epileptic foci. The area of resection does not encroach onto functional areas that need to be preserved. And of course, the benefit outweighs the considered risk for the proposed surgery. So in anterior mesial temporal lobectomy, what we basically do is that we resect the lateral temporal and temporal structures first to gain access to the mesial temporal structures. Once we gain access to the mesial temporal structures, we will then be able to remove the hippocampus and block. But in our hospital, usually we divide the hippocampus into 3 parts: the head, the body, and the tail. So to differentiate the body from the head, we will firstly identify the inferior choroidal point. So this is how we position the patient. The patient will be done under general anesthesia, put on a 3-pin head clamp, a shoulder roll behind the neck. Neck would be fully extended, malar eminence as the highest point. Head will be turned 60 degrees to the contralateral side. Our incision is a small question mark incision, carefully designed to preserve the STA and also inside the hairline. Okay, and after opening the skin, we'll flip up, retract the skin, the scalp forwards, and we will do a myo-osteofacial flap in which the muscle is attached to the bone. So by doing this technique, we realize that post-operatively, the patient rarely has any atrophy of the temporal muscle. So it is very important to know the trajectory during doing the surgery. So we have 2 trajectories. So after opening the bone and the dura, we will first have this first trajectory where we will angle the microscope about 45 degrees. This is to ensure that we do not enter the ventricles prematurely, and we will always be in the safe zone within the bony landmarks. So the first trajectory, we will aim to take out the lateral neocortex first. Then, once this is performed satisfactory to the para-hippocampal or the fusiform gyrus commonly, then we will then angle our body as well and the microscope to about 80 to 90 degrees from the cortex. So the first step is then we will then look for we will try to enter the ventricles first. Once we get the ventricles, then we will then put the retractor perpendicularly to the surface of the cortex, identify the choroid plexus and also the ICP point. So the ICP point is very important because the anterior choroidal artery will be there. So that would have to be carefully preserved, and no burning, strictly no burning is to be performed at that region. So once we identify that, we will be able to visualize the hippocampus at that point. So keeping in mind that there are multiple blood vessels very, very nearby, and if we go beyond the PR, we will injure all the vascular supply. So before we go in deeper there, I would like to draw your attention to the lateral neocortical incision. So first of all, we have to identify the Sylvian veins and also the vein of Labbé. Then the next step is to identify the superior temporal gyrus, middle and inferior temporal gyrus. So usually with this technique, we can only visualize the Sylvian veins and the superior temporal gyrus and some of the middle temporal gyrus. So what we do is that we will put patties in the same line on the Sylvian veins in this direction. So one patty over here covering the Sylvian veins, another patty covering the superior temporal gyrus. Then you can tilt your microscope down to see the bony structures. Usually here there is a tubercle, which is the unnamed tubercle, which most of the time corresponds to the vein of Labbé. So this is one of the side projects topics that we are planning to publish in the near future, but currently the data is still not available yet for this anatomical study. So for the vein of Labbé, then we will put another patty in this direction. So covering all the important areas, then we will then do the neocortical incision, where we will cut the middle part of the temporal gyrus first, and another incision down to the unnamed tubercle in front of the vein of Labbé. Well, certainly, I think a lot of papers has quoted that in the right side, you may go up to about 5.5 centimeters and the left side up to 4 centimeters, which we are also following closely. So this is how we do it. So after doing it, then we will take out the neocortex. So at this area, it is very important to preserve part of the PR, because after this neocortical incision, we will then proceed with the subchial dissection, removing, especially when you start from the cruciform gyrus onwards. The PR, the very thin PR, has to be preserved. Okay, so these are some videos showing how we remove the hippocampus. So here, this is our roton microdissector. You can either use number 4 or number 6, and sucker to hold on to the PR. And we will then slowly tease the parahippocampal gyrus out. This is a subsequent video of us removing the head of the hippocampus. So if there's any bleeding, we do not burn. We will, most of the time, we'll put a patty of Surgicel, it will stop by itself. So strictly no burning in this region. Because beyond this area, as you can see, this is the falx here. So beyond that would be all the important oculomotor nerves. You can see the brainstem and also the blood vessels surrounding it. Okay. So continuation of the video. So at this area, we will then use the forceps, a very, very sharp forceps, bayoneted forceps, to then using the pinching technique to slowly, gently pinch and remove the thing and block, if possible. If not possible, then we will do it in piecemeal method. So some of the landmarks that we use to achieve safe resection, these Wern's cortical, carotid cortical line. where we will draw an imaginary line starting from the ICA bifurcation to the proximal M1, and anything there in front of it, we can safely remove. And we also use this line to safely determine the extent of amygdala removal. So these are one of the pictures that we remove. So this is the hippocampus, uncal sulcus, and the amygdala. And this is what you will see at the end of the surgery. So the head, body, and then how do we remove the tail? Well, we will then move our microscope and tilt it backwards. Then we will use the cup microforceps to slowly piecemeal remove it. So, however, very importantly, to achieve very good outcome, we realize that pre-surgical investigations are very, very important. This includes proper history and physical examination, EEG, brain MRI, video EEG, and also neuropsychology and neuropsychiatry assessment. So our project is actually under the National Adult Epilepsy Program, which has been running for the past 12 years. This is our MDT team, which consists of our neurologist, Dr. Suganti, and the neurosurgeons, our fellow neuroradiologists, neuropsychiatrists, and neuropsychologists. So during the MDT, which will be held about 1 to 2 times per year, we will discuss all the cases that are considered for surgery. So for the past 12 years, we have had 22 MDTs and discussed a total of 189 patients. Surgical candidates identified were 144, and out of these, for ATL, we decided for ATL was 101 patients. So during COVID time, we were very grateful that Hospital Kuala Lumpur were able to help us to continue this project. So in Hospital Sungai Buloh, we have operated of about 89 patients. So this is a little bit about our MDT. So the aim is to establish diagnosis, to define electrical clinical syndrome, delineate the lesion, and to select the ideal candidate. Then we will then determine the type of surgery for the patient. So these are some of the pictures that we have during our MDT. So our MDT will run at starting from about 8 a.m. to sometimes we finish at about 6 p.m. because of the amount of patients and the duration. We take about 30 minutes to 1 hour discussing each and every patient diligently. So in Sungai Buloh, we had 89 patients. The age range about 20 to 65 years old. We had 46 right ATL and 43 left ATL, 35 males, 54 females. All the patients were operated using the Spencer's technique. Non-dominant neocortical incision, we cut until 5.5. The left side, sometimes, most of the time, we cut until 4.5 centimeters. We aim to achieve maximal removal, but however, one of our subgroup analysis, radiographic subgroup analysis, we noticed that sometimes the tail gets left behind. So, but for head and body, most of the time we managed to get everything out. The AEDs were then continued strictly for 1 year post-operatively and will be then be reassessed by the neurologist in charge whether to taper it or to continue it. We will then routinely follow up the patients at 2 weeks, 1 month, 3 months, 6 months, and 1 year. We will then perform an MRI at 6 weeks to 9 weeks time. And post-operatively, they will continue their neurology, neuropsychiatry, and neuropsychology follow-up. So to look into the outcome, we use the angle classification in which we have 4 classes. Class 1 would be free of disabling seizures. Class 2, rare disabling seizures. Class 3, worthwhile improvement. Class 4, no worthwhile improvement. So this is our analysis. We only included 86 of the patients because 3 patients were just operated, so we did not include in this data. So of the the patients operated in less than 1 year, all 5 of them achieved angle 1 seizure outcome. 1 to 3, we have 1 to 3 years, we have about 20 patients. Majority of the patients, 90% of the patients achieved angle 1. At 3 to 5 years, we have also 20 patients. 90% of the patients achieve angle 1. More than 5 years, we have about 41 patients. So out of these 41 patients, 34 patients achieved angle 1. So in total, we can achieve about 91.5% angle 1. So So in terms of quality of life, we use the quality of life scale. 1, highly unsatisfied. 2, unsatisfied. 3, not much improvement in quality of life. 4, satisfied, some improvement, and 5, very satisfied. So how did the patient fare? Up to 65% of the patients were very happy and very satisfied with a very marked improvement in quality of life. Up to 19% had some improvements in quality of life, but 9% of the patients were not very satisfied. How about unwanted events? So to compare with the meta-analysis published by Merriam et al. In 2020, for our hospital, we had 1 surgical death, which occurred earlier on when we started the program in 2012-2013. 4 patients sustained cognitive deficit. 2 patients had worsening psychiatric illnesses. 2 patients had transient hemiparesis. 1 patient had symptomatic visual deficit, and 1 patient had infection. So our complication rate is about 11.6% over the past 12 years. Unexpected non-surgical death, we had 4 patients. So while following up, we had 1 patient who passed away suddenly, in which we were suspecting SUDEP, candidate number 44, and another 2 patients after being followed up for more than 5 years. 1 patient passed away due to complications of the underlying GPS disease, Guillain-Barré syndrome. What about unexpected visual field loss? We had 1 patient, number 77. He complained of complete loss, vision loss of the right eye. However, when we checked clinically with the MRI and also ophthalmologically, there were no abnormalities found. So the patient had subsequently quit his job as a lorry driver, but currently the cause is still, we're still investigating and not sure what's the reason. So the most common cause actually for ATLs are homonymous quadranopsia, the pie in the sky. The frequency internationally quoted is as high as 50%, but only 8% of the patients being symptomatic. And it's commonly due to the injury to the Meniere's loop. But it's very rare in our studies. In our group of patients, of 86 patients, I think none of them had this visual field deficit. What about unexpected hemiparesis? We had 2 patients, number 56 and number 66. So post-op, we had a scare actually because the patient could not move the contralateral side after extubation. So we did an immediate scan, but we found no significant findings. But because at that time, we were suspecting excessive manipulation of the choroid plexus, causing anterior choroidal artery vasospasm. So we instituted nimodipine and also IV dexamethasone, not prednisone, dexamethasone. Luckily for us, both patients regained full neurological recovery within 24 hours. So when we look into the literature, we see that the quoted percentage is actually up to 4%, and it is due to the injury to the pyramidal tract or the causes of vasospasm due to of the anterior choroidal artery. So the treatment that the institute recommended is also nimodipine. So For cognitive deficit psychiatric changes, candidate number 13 had severe decline in memory after it left ATL, and number 32 had severe psychosis. So post-op MRI, we also checked diligently. The new cortical resection for these two cases were less than 4 centimeters on the left side. But when we followed them up long-term, more than 5 years, both of them actually achieved seizure freedom angle 1. But unfortunate for them, they had quit their job because of all these issues. So internationally, this is the most common complication, cited 5 to 7%. And this is one of the reasons why we insist that all of our patients, 100% of our patients, must continue their neuropsychiatry and neuropsychology follow-up. All of our patients were assessed before surgery for any pre-existing neuropsychiatry issues as well. Okay. So we have 4 patients who had persistent seizures, and we grouped them under the category of failed surgery. For failed surgery, we take the angle 3 and angle 4. So they were candidates patient number 11, 35, 42, and 27. So the seizures actually came back within 2 weeks after surgery. When we retrospectively look into the history, we noted that all of these patients had history of febrile seizures or meningitis. And we also noticed that the patients had some residual over the head and the body. So now for the past 5 years, we try to achieve maximum resection of the head and body. So these are some of the things that we have been trying to evolve. So we identified the 5 main causes. So insufficient resection, and also insufficient resection of the temporal neocortex, and perhaps the patient had dual pathology, or relapse of the contralateral temporal lobe, or any extratemporal epilepsies. So in conclusion, ATL in our center, we think is a very good method of treatment. It is very cost effective and generally safe, with up to 90% of seizure freedom. But of course, we realize that it is very important to have good case selection, because good case selection almost equals to the predictor of seizure freedom post-surgery. Complications are rare, but can be catastrophic. So these are some of our patients. Okay, thank you.
Thank you, Dr. Xin Liu, for the very nice presentation. And I think we can open the discussion about this presentation. So I invite our commentators and discussants to share their comments. Dr. Lucina, Dr. Dilshad, Sukirti.
Thank you so much, Professor, for this very extensive and comprehensive discussion. And also, I really learned a lot. And here in the Philippines, it's more or less epilepsy surgery has not really very well taken off, no? And as much as possible, the patients here, they contend with not just 2, but 3, up to sometimes I see 4 anti-epileptic drugs that they really tend to control the seizure of these patients. My question is, number 1, how young is this kind of surgery applicable to? And number 2, when you say good patient selection, does it mean that even the economics, is economics also a factor in the surgery? Because it's always a factor always in a country like ours, in the Philippines. So I don't know, we don't have any study relating the economy of giving a lot of anti-seizure versus undergoing an epilepsy surgery. Okay, and my third question is that the memory loss, how do you explain these possible rare complications to so that to the patients that you will select? Thank you.
Thank you very much, Professor, for your kind words. I try to deliver the presentation, but I'm a little bit nervous because it's the first time. So we're in our epilepsy program, we mainly deal with adult epilepsy, but from my understanding is that we also have our pediatric epilepsy group, which is headed by Dr. Asmi in HKL. So for our MDT, which is headed by our extremely very good, hardworking neurologist, Dr. Suganti, she will identify ages more than 17. Actually, she will then send to us. But I think in our in the things that I presented, the youngest patient that we had was actually 20 years old. So those younger than 17 years old actually would be under the pediatric group, which will be sent to another hospital. So another thing is about the patient selection. So patient selection mainly will be done by our neurologists. But then we will then discuss the case extensively. So for each case during the MDT, we will spend about 30 minutes to 45 minutes. All of us will be giving our opinions, and especially the neuropsychiatrists and also the neuropsychologists will assess them properly. So we will get very, very good social history, especially from our psychiatric colleagues and psychologist colleagues. So they will tell us their economic status and also how good is their family support. So generally, those with poor family support, we do not really recommend ATL. The reason is because the post-operative recovery period is very, very important for the patients. So without good family support, if they feel neglected, all these things, so we will not select them as our candidate for ATL. If they do not have any major red flags, such as schizophrenia, which will be in a harm to the patient themselves or the doctors, then would be a candidate for this surgery. I hope I answered your questions. Thank you.
Thank you.
Another thing is about the cost effectiveness. It is actually very, very, I feel that it is very cost effective because we don't spend, basically our patients do not need to pay any money. If you are a Malaysian and if you have the IC, basically everything is free. I think maximum you need to pay is about 5 ringgit. 5 ringgit is about, one ringgit is about 300 yen. So it's less than 1,000 yen. Yeah. Yes, less than 1,000 yen to do the surgery, yes. So, yeah, even though they are economically well off, but in our government hospital in Sungai Buloh, we do not charge the patient excessively. But in other cases, if we have those patients who are very well off and they are also very knowledgeable. So most of the time they will tell us they read a thing called TESOL. No, they are very, very well educated. So they will tell us, oh, I read you have a list of complications. Sometimes I hear about infection, then they will ask a lot of questions. Sometimes they request, after surgery, can I have a very high-end antibiotics, something like that. But usually we do not charge them. Yeah. And we also do not use IOM because in my hospital, if you use intraoperative monitoring, it's charged. So for ATL patients, we also do not use IOM. So it is very cost effective.
Thank you.
Thank you. Sukirti?
Yeah, hi, Dr. Zinli. Excellent talk. Well, I have this interest in epilepsy and I have been seeing a lot of patients. My question is very simple. You said that when patients on 2 anti-epileptics or anti-seizure medication over 2 years, and then you consider surgery if they're refractory to that. So after surgery, how many anti-epileptic drugs are they on, and when do they really stop the drugs?
Thank you for your question. So yes, most of the time my patients come in with 2. Most of the time they come in with 3 or more types of
That's
antiepileptics.
common.
So they will have 18 to sometimes 50 pills to take every day. So post-op, we strictly continue the anti-epileptics. We do not reduce it. Sometimes because after surgery, they feel really great. They go for jogging at 3 months post-surgery, and then they stop the anti-epileptics themselves. But because they will be followed up by our neurologist, our Dr. Sugansky, so strictly we keep until 1 year. After 1 year, seizure-free, then we will slowly cut down. But that is in the perjury of our neurologist. So for our ATL, actually, the neurosurgeons will play a role, but we play a big role in the surgical intervention. But it is a group effort lah. So we have our neurologists, our neuropsychiatrists, neuropsychologists even, to help us on all these things. And even post-op, the MRI is being dealt by our neuroradiologist, Dr. Rose.
Thank you. Thank you.
Thank you. Any comment from our commentator, Dilshad?
Thank you, Dr. Shinli Yu. Do you have any comparative study conducted before this having the decision of the anterior temporal lobe lesionectomy? You have a comparative study with the selective amygdala hippocampectomy versus ATL procedure, which give you the decision of doing ATL more. I mean, it's more recommended by the world literature or any other your comparative study.
Thank you for your question. So we are aware that SBA and also SBA is generally better recommended. But in my hospital, we only have this option of ATL. And it's spearheaded by my consultant and head of department and head of the state, Dr. Saiful. So we do not have a side-by-side comparison, unfortunately, because we have this ATL available. And with this ATL, the angle 1 achievement is actually 90%. So at this moment, we do not have plans to adopt SEA yet.
Thank you.
Thank you. Ben?
Yes, hello. And thank you for your great presentation, a very comprehensive one. And congratulations on your results. I would like to ask about, upon your reflection on your surgery and pre-operative investigation for your epilepsy surgeries. So I would like to ask about your opinion. How would you improve your investigation in refractory epilepsies for whose patient you cannot find the epileptic focus? So would you consider, for example, like stereotactic EEG, or do you think in your current settings, any advanced imaging technique is lacking in your setting? So what's your opinion?
Definitely, Malaysia, we are still a developing country. So what we have now is MRI and also video EEG. So I guess in the future we have a lot to think about to learn the new techniques, functional MRI and grid electrodes, EEG, subdural grids, etc. Yeah.
Yes, indeed. Thank you so much. And some further advanced technology are available, like MR pad and MEG, for example, like to further evaluate. I am sure that the epilepsy surgeries under your supervision will continue to improve. And thank you so much, and congratulations.
Yes, it's a very important point, I think. So the preoperative setting and checkup. So you showed really brilliant surgery and great results. And I also wish you can go on with your work, improving also this kind of preoperative examinations, which are actually sometimes crucial, right, to give indication to surgery to some patients. In some cases, I do remember some cases at my previous hospital where giving indication to surgery for epilepsy was not so easy, and only some invasive recordings or some advanced MRI techniques were useful to take a decision. I also have a very quick question about the initial part of your resection. Do you spare the T1, the superior temporal gyrus all the time? I'm asking because I do sometimes remove the most anterior part, the very anterior part, like 1 centimeter of T1, because this gives me more clear vision of the line between the inferior choroidal point and the carotid artery for cutting the amygdala. And also, how do you have any mean to understand how much of the amygdala you can remove? Because actually it's a very difficult assessment during surgery. While you can see very clearly the hippocampus, the amygdala is not so clearly seen. You don't have so nice anatomical landmarks besides the very indirect line between the inferior choroidal point and the carotid artery. So do you have any trick to extend your resection of the amygdala without increasing the risks?
Actually, you raised a very valid point. Yes, for the superior temporal gyrus, we do retain it, but the temporal pole, the most anterior portion, the temporal pole up to 1 centimeter, we do remove that part, but only applies to the superior temporal gyrus 1 centimeter only. But sometimes we realize that the anatomy of the Sylvian veins, there are large veins over there. So sometimes at that point, we will just do a subhyoid dissection and leave the main veins behind. So that is one of the things that we are anatomical paper that we are trying to do right now, but the data is still ongoing. So perhaps in next few years, we will have some data on the Sylvian vein variation anatomy on that. So I do agree that amygdala is a very difficult structure to identify. But I do realize that when you're reaching the amygdala, the consistency over that area using the sucker, when you do suck gently, it is there is some firm gritty sensation over there. So to signify the amygdala is over there. And we also use the Wern's line, which is the line drawn at, from the anterior choroidal point to the imaginary M1 bifurcation line. So that is one of our guide for removal, safe removal of the amygdala. So apart from the amygdala, actually one of the things that I feel that is also a bit difficult is to get into the temporal horn, the temporal horn of the ventricle. So when we move the microscope, because the first part is that we'll put 45 degrees. Then after that, we will try to go straight 90 degrees down. So at that moment, it is very important to not overshoot. So always zoom out to see where you are, and always check whether you're inside the PR and all these things. So the amygdala is one of the things that we also have some difficulty. Yeah. But otherwise, the other parts of the superior temporal gyrus, we have to strictly protect, and also the sibling veins, that is a must. And when we go in, sometimes we will just push the bipolar pedal away to prevent us from accidentally, buzzing any leaders. Yeah.
Right. Thank you very much. I was asking because you showed a very, very beautiful sample during your presentation with the hippocampus and the amygdala, which was very clear in that image. So congratulations for the very nice talk. Let me ask the floor if there are other questions. I don't know, Sharon or others.
I just want to say thank you to Xin-Li for the great presentation. Actually, I was in the MDT from 2012 to 2022 before I left government service. So just to say for anyone who wants to develop this in their hospital, I think it's very important to work closely with the neurologist, because I think the reason why epilepsy surgery started in our country was because the neurologist actually really pushed for it. She was very passionate about her patients, and she wanted something to be done. So Lynn, this is one of the ways you all can go forward, is you need to work with the neurologist very closely. And because she's very passionate, you can ask Xin-Li. She's actually the, how do you say, a post-op police. She actually comes around and she will question you every time post-operatively, looking at your MRIs and the post-op MRIs and samples, and actually question you if you've actually adequately done your surgery. So she keeps you on your toes. So I think that's very important. Going forward, I think, thank you very much, Xin-Li. Anyone else wants to give any comments? Or maybe Abida?
Yeah, Sharon. I think very good presentation, Xin-Li, you. And we do it a little differently. The basic concept is the same, but we make a cortical incision in the middle temporal gyrus, not going from the sulcus. We enter into the gyrus in the most anterior part of the temporal horn. Because if you see the anatomy, in that part of the temporal horn, the fibers of the Meyers's loop and the IFOF are in the roof. So if you are actually entering the temporal horn below the roof, and then we remove the whole amygdalo, hippocampus, and the neocortex in one block. So not the lateral neocortex first and then the amygdalohippocampectomy. So you enter just below the roof in the temporal horn and then resect it in one block, remaining below the roof. Then we have seen that this avoids injury to the Meyers's loop, because you're not in any way encountering them. So that is a little different way that we do the amygdalohippocampectomy. And yes, for epilepsy, you have to have a multidisciplinary team. That is the core of the whole thing, because we are just the surgical part. The neurologist and the neuropsychologist are the ones deciding which candidate is suitable for the resection. I have a question for you. Sometimes you don't use ECOG guided resections, to suppose there is a patient with some mesial temporal focus and also a little focus on the neocortex. How do you, do you use ECOG, or you just do a anterior temporal lobectomy with amygdalohippocampectomy?
Thank you for the question, and thank you for your kind word. Our technique is certainly different from yours. So we divide the surgery procedure to two parts, where we take out the neocortex first, then the mesial temporal gyrus, then the mesial temporal structures. Yeah. So ECOG, we don't use ECOG. So we don't use ECOG.
Okay, that's good. We use it in some cases, especially if there's some dysplasia or something along with the mesial, mesial discharges, then sometimes we add an ECOG, but I know that it works well without an ECOG also. So thank you. Nice presentation.
I would say that epilepsy surgery in Malaysia is still, I think, still young. So we still have a lot to learn from other professors as well. Yeah. Thank you for your comment.
Yeah, I would say still young, but you have a very nice series. So congratulations for your presentation. So I think we can, at this point, move on with the introduction of the new fellows, if they are connected. I know there are 2 doctors and 2 nurse practitioners at Fujita Bantané Hospital. I'm asking if we have Dr. Ruzan Nazinyan and Dr. Mokira Jarolova connected. I don't see them.
Oh, maybe that Mohira will reach the third, not today.
Okay.
Sorry.
And maybe we have the two nurse practitioners, Pham Huyen Trang and Pham Thi Song.
Hello.
Yes, they connected. Yes,
hello.
yes.
Oh, yes.
They sit together.
My name's Sơn. I'm a nurse.
Konbanwa.
I'm a nurse from Vietnam. I have worked in the neurosurgery department at 𝒃𝒉𝒂 Hospital in Hanoi for 26. I come to Japan to study the advancement in neurosurgery. Care under mentorship of Professor 𝒂𝒂 thank you for giving me this opportunity.
You've just arrived, so maybe tired.
Just arrived. So we wish you, and you are two, right? Two nurse practitioners, both from Vietnam, I guess. Nice.
Another one. Hello.
Yeah, maybe your colleague wants to introduce herself.
Hi everyone, my name is Trang. I'm a nurse from Vietnam. I have I'm a nurse from Vietnam. I have worked in the neurosurgery department at 𝒃𝒃 Hospital in Hanoi for 16. I came from Japan to study and advance in neurosurgery neurological care under mentorship of Professor Yoko Kato. Thank you for giving me this opportunity.
Thank you very much, and you are welcome to Fujita Bantané, and we wish you all the best for this period in Japan. I'm sure you will get the best from this experience.
Yes, thank you so much.
Thank you.
All the best for your next 1 month, please.
Yes,
just 1 month. They are staying with us 1 month till January.
Nice, nice. So I think we can finish this webinar, but first of all, I would like to ask Dr. Sharon to give some words to close this session. Dr. Sharon, who is the, of course, chair of the WIN chapter.
You're muted. You're muted, Sharon.
All right.
Okay, great. Now we can hear you.
I'd like to, first of all, to thank Professor Abida and also UZIMLI for presenting today, so graciously coming on and presenting today. I'd like to thank Lynn for joining us in such short notice. Thank you so much, Lynn. And also thank you, Alberto, for giving us, WIN, this opportunity. And most of all, thank you, Professor Kato, for always being there and supporting the WIN Society in general. Thank you very much.
Thank you, Sharon. Thank you to the WIN chapter. I also want to add some thanks to Dr. Dilshot Mammadaliev, who was our commentator today, and also to our discussants. Again, thank you to Dr. Boone, Dr. Raja for helping always with the organization. And a big thanks to Professor Yoko Kato, and I would like to give the floor to Professor Kato for some closing remarks.
Thank you so much. And first of all, thank you very much, Professor Fawad, all the time you support us, and also maybe I think in the future, maybe we can more collaboration We are so sorry about the shortage of some instruments, some materials. So maybe you can send us the young colleagues to study, maybe Abida Shah or some other doctors, please. Today we had a very nice, the excellent talk, and Abida Shah is of course almost equal to, maybe beyond the Atul Goyal now, I think. And also the young speaker, the Shinji Yu. Thank you very much. So you came to the winter seminar, right?
Yes, Professor, I went 2019.
Yes. I still remember the nice smile face. Thank you very much. So
yes.
I think yeah. Now it's very, very less invasive surgery, especially for epileptic surgery. I think more and more the drug day by day. So anti-epileptic drug is coming up day by day. So I think maybe the indication is very, very crucial, very important, I think. But all the best wishes. Shah, maybe I think the very simple surgery that you showed us today, we done a lot. Maybe in the future, I think the more interest the spinal, the lesion is a bit less interest for neurosurgeon, I think. Maybe you can invade to more educate for awareness in the future. Thank you very much all. And then two nurses from Hanoi, please enjoy your stay in Japan and also the study together next 1 month. Thank you very much.
Thank you, Professor Yoko Kato, for your words. And again, thank you to Abida and Xin Li for wonderful presentations today. I want to thank the Women in Neurosurgery chapter for accepting this invitation for a joint webinar. I think it was a very successful one, and I hope it will be only the first of a longer series of collaboration. I think we need to join forces to improve our ability to reach more young neurosurgeons, male and female, and share more knowledge. So thank you to all of you, and see you next time.
Yes.
Bye-bye.
Thank you very much.
Arigato.
Thank you.
Arigato gozaimasu.
おやすみなさい。おやすみなさい。
ありがとう。